to that of yesterday. And we are now dealing with I think the others will just follow. So we're now dealing now with the disorders of the pleura. Okay. So I believe that you know that the pleura has one, the parietal and the visceral pleura. The visceral pleura is the one that adheres into the lungs, be it the viscera. So that's why it's called visceral pleura. And the one that adheres in just wall cavity is known as your pharynx. It's the one that is very important in our discussion with our topic this evening, no, because one of the most common condition that involves the pleura is a pleural effusion. Okay, so we know that the parietal pleura is derived from your somatopleural mesoderm, and it has some form of somatic innervation. So on the body wall, it is innervated by your intercostal nerves, and in the diaphragm, the mediastinum is supplied by your phrenic nerves. And that from this, we will know that pain from the involvement of your pleura is therefore they are felt on the body wall or in the dermatomes of the phrenic nerves. So they are actually distributed into that. So whereas the visceral pleura naman is derived from your splanchnic pleural mesoderm, and it has some autonomic innervation. Now, what is of note here is that the visceral pleura is insensitive to pain and temperature stimuli. So that even though if you poke the lungs or in the visceral pleura is there, pain is oftentimes not manifested, unlike in the parietal pleura, wherein it's really painful. And what is uh, masama pa, no? Because when you do your thoracentesis and you try to infiltrate the skin and then the dermis and then the underlying tissues, it is the parietal pleura that is not infiltrated with your anesthesia. That's why it's still painful. So the pleural space naman is a space, no, that contains thin fluid that will serve as lubrication. They are secreted by your capillaries of your parietal, and it has been said that it is absorbed, no, in the lymphatics, which is situated also in your parietal pleura, and it is absorbed 20 times faster than it is produced. That's why they usually don't accumulate in the pleural space to produce your effusion. Now, fluid can also access the pleural cavity from the abdominal cavity through the tiny holes in the diaphragm. That's the reason why sometimes in a patient who is having what do you call this, a very large ascites can also manifest as effusion because of the tiny holes in the diaphragm wherein your fluid from the abdomen can gain access into your thoracic cavity. So this is one of the condition that is very common, no, in our patients that involves the pleura. We have to remember that pleural effusion will never occur if what involve the pleura. It is always there's always involvement of the pleura that causes the effusion. So there are some patients who would saying, why is it that he also has TB pero wala effusion, whereas I have a TB and I have effusion. It's because that the person with effusion has involvement of the pleura that causes the effusion. Otherwise, if it involves only the lung parenchyma, pleural effusion will occur. So it would range from either a minimal pleural effusion to moderate or to a large pleural effusion. Okay. Now, they say that pleural effusion is an excess in the quantity of the pleural fluid, and it's oftentimes because of the imbalance between the formation and the absorption. So if the absorption is outweighed with the formation of fluid, then pleural effusion would ensue. So the mechanism for the development of pleural effusion is that there's some form of an injury in the pleura that causes an increased permeability and with your high rich protein-rich exudates. Or there could be an imbalance between the hydrostatic forces and that of the aquatic forces that causes the protein for transsudates to gain access into the pleural space. Or there could be an extravasation of the fluid from the lymphatic or vascular structures or from the adjacent body compartment into the pleural space, just like the abdomen going into the the pleural space. Okay, so here is just to show to you the formation of your effusion. So fluid in the capillary space, or it could be coming from the abdomen and that seep into the diaphragm, or from the interstitial spaces in the lungs or visceral pleura. It is being absorbed by your lymphatics, but in cases when there's a blockage in the lymphatic, then there might be an increase in the fluid that accumulate in the space, causing your pleural effusion. Okay, and one diagnostic procedure that we should do in a patient with pleural effusion is thoracentesis. So when we do thoracentesis, what we would like to examine here with the fluid, and we have to perform this diagnostic mga examinations such as your pH, the protein, and your LDH, and other also mga things we should request, no, the laboratory for in our diagnosis. And we have to remember that we have to determine whether the effusion is either an exudative or a transudative type of effusion. So we have to remember what is important is the protein, the LDH, and the pleural fluid, protein and the LDH. Now, ideally, we had to determine or get the pleural fluid and the serum protein, and then get the ratio, and then also the LDH para maka-arrive kita into diagnosis of whether this infusion is an exudative type. So a PF serum protein ratio of greater than 0.5, or a PF serum LDH ratio of 0.6, or a PF LDH which is about two-thirds the upper normal serum limit would suggest that this fluid is exudative type. Otherwise, if it is lesser than this one, then it is a transudative type. Okay? So we have here the Light's criteria, no, in determining whether the fluid is exudative or transudative. The one that I was discussing a while ago is that of the Light's criteria. But there's also one rule that does not require the serum testing of your protein and your cholesterol. So a PF protein of greater than 2.9 grams per deciliter, or a PF cholesterol of greater than 45 milligrams per deciliter, or a PF LDH of greater than 0.45 times the upper limit of the laboratory normal serum LDH would suggest that that effusion is that of an exudative type. Okay, so this one is using the Lyle's criteria, wherein you get the ratio between the pleural fluid and that of the serum, whereas this one relies only on the pleural fluid protein and your cholesterol. Okay. So this is now the diagnostic approach that we can do in our patients. So if we have an exudative type of effusion, then we have to measure all this. You can have also to request for the cytology, because one of the differential diagnosis of an exudative pleural effusion is that of malignancy. We should also have to ask for cell count, the differential count, then a marker for TB, no? And then we have also to request for serum amylase, just in case we are suspecting the possibility of a pancreatic cancer or pancreatitis causing the effusion, or in cases when we suspect malignancy. Then we also have to request for a glucose. A glucose of less than 60 milligrams per deciliter may suggest that this is probably a malignant effusion, or it may be secondary to bacterial infection or from a rheumatoid arthritis. Now, this is the most common cause of your transudative type of effusion. Number one stage would be your congestive heart failure, followed by your cirrhosis of the liver. You can have your pulmonary embolism, nephrotic syndrome, complex edema, or your urinothorax. So those are the most common cause of tertiary effusion. But in cases when you don't have diagnosis, can you still hear me? Hello?
Yes, Doc.
Yes po,
Oh,
Doc.
okay, because it baga nasa limang hudi nga unstable ko ng takot internet. But anyways, so if you don't have any diagnosis, the examination of your fluid is not diagnostic, then think of possible pulmonary embolism, where you should order for spiral CT or lung scan. And then if it shows some evidences that this is otherwise known as pulmonary embolism, then you have to treat accordingly. But if not, then you go for a PF marker for TB. So if it is positive, then treat for TB. But if it's negative and the symptoms improve, then you can just do thoracoscopy or do some pleural biopsy. But if the symptom is not improving, if it's not improving, do thoracoscopy. I'm sorry, and then pleural biopsy because you might be thinking of possible malignancy. But if it does improve, then you just have to observe. Right? Now, okay, so different diagnosis of pleural effusion is you have your transurethric type. So as what I've said, the most common still congestion. Then you have followed by your cirrhosis, embolism, nephrotic syndrome in patients who's having some peritoneal dialysis, probably because of the seepage of fluid from the peritoneum into the chest cavity, or it could be the SPC syndrome or a mixed edema. So, exudative pleural effusion, mas madami dito, ano? You can have the plastic diseases, could be infectious, pulmonary embolization, GI, post-coronary bypass surgery, asbestos, sarcoidosis, mixed syndrome, yellow nail syndrome. You can have some GI disorders. Collagen vascular diseases could be drug-induced pleural diseases, a tract lung, radiation therapy, post-cardiac injury syndrome, hemothorax, iatrogenic injury, can also a pericardial disease or a chylothorax. Okay, so these are the different conditions that you may consider in a patient who have an exudative type of pleural effusion. So medyo mas marami siya as compared to that of your transurethric type. So again, this one, your pleural effusion, you can actually, when you do your thoracentesis, then please do examine the physical characteristic of the effusion. So we have here 1, 2, 3, and 4. And the take of possibility, this one is a little bit clear. This one is turbid. This is bloody. Ito naman is parang brownish ang color niya. So from here, we'll be able to deduce whether the effusion is ito kasi is turbid, no? So most probably this is an empyema. Dito kasi this is more of a transurethric type like that. Okay, so from here we'll be able to get our differential diagnosis on what we got from the thoracentis 3D. So again, sorry, most common would be the effusion due to heart failure. Of course, in about 50 to 90% of cases. More often, it is coming from your left ventricular failure with 58% of cases. Now, effusion due to heart failure is oftentimes bilateral, and there's a characteristic increasing dyspnea on exertion, accompanied by your peripheral edema or orthopnea or paroxysmal nocturnal dyspnea, and a dyspnea which is out of proportion of the size of diffusion. Now, there are actually two conditions that we have to consider in a patient who is very much dyspneic, but when you take a look at the size of the effusion, it does not match. No? So one would be the effusion because of heart failure, and then one is because of malignancy. So these are the two conditions that you might consider in a patient who are dyspneic, so much dyspneic pero butehela itong effusion. Okay, but it's very easy for heart failure because you have other signs of heart failure that you have to look into. No, so you can have your engorgement of neck veins, peripheral edema, but in a patient who are having malignancy, in which the dyspnea is out of proportion to size diffusion, and it's not coupled with the signs and symptoms of congestive heart failure, then think of a possible malignancy. Okay. So on PE again, you can have distension of the neck veins, you have roused, and then S3 gallop. So radiographically, what you will see here would be, okay, this one is bilateral, and as you can see here, what do you call this? This is a meniscus sign, no? So this is indicative of presence of malignancy, of fluid in the pleural cavity. So other things that you should take a look would be the size of the heart. Okay, so if there's cardiomegaly or it is more than half the size of one side of the chest, then most probably there is cardiomegaly or increase in the size of the heart. Then there should also be cephalization of the vessels, and then there would be curly B lines. No, actually mga projections ito itong mga the vasculatures in the lungs. And this is just pleural effusion. This is an effusion that has gained access into the what do you call this? The lobar fissure. Okay, so this is the pleural effusion. Sometimes mamimiss mo niya. You can just this can be misdiagnosed as a pneumonia, but this is a form of effusion that seeps into uh, the in between the lobes of the lungs. Okay, so again, you do your thoracentesis, and then once you do your thoracentesis, okay, these are the indication actually of doing thoracentesis in a patient whom you are suspecting of having heart failure. One is if it is a unilateral effusion, bilateral but not comparable in size. There's presence of fever, there's a pleuritic chest pain, and there's no response to diuresis. Because more often than not, in a patient who are have congestion, uh, they do respond to the giving of your diuretics. And then fever, oftentimes patient with congestion doesn't also usually have fever, but if it has some fever, then most probably it is an infectious type of infusion rather than due to heart failure. So oftentimes bilateral, but again, is not comparable in size. And if you have a unilateral effusion, although we're not saying that 100% of the effusion due to heart failure is bilateral, but just to be very sure, then if you have a unilateral effusion, then do some examination or do the procedure of thoracentesis. You can give your diuretics actually in cases wherein you have effusion, especially if the effusion is just minimal. No. Okay, so what is of note here talaga is make sure lang, no, word of advice, that if you do thoracentesis, you have to do some x-rays or a geographic examination after the procedure just to make sure that there's already been reduction in the size of the effusion. And sometimes you can get mga information after the fluid is removed. You'll be able to see mga pneumonia or mass or whatever. Okay. So next will be the hepatic hydrothorax. So definitely when you uh, think of hepatic, that means it is usually a complication of cirrhosis of the liver. Now, it usually occurs when the acidic fluid is present in 5.5% of cases. Oftentimes, it is right-sided, no, in 60% of cases, but can also occur in 16% of cases in the left side, and 16 also can occur as bilateral. But oftentimes, it is right-sided because the liver is located at the right side of the body. Okay. Now, it is because of the decrease in your plasma oncotic pressure that moves your fluid from your peritoneum, gaining access into your thoracic cavity. Now, oh, I was lost, right? Can you hear me?
Yes po, Doc.
Nawala ba ako?
Yes po.
Nag- Nag-reconnect kasi. Anyways, so I was saying, no, we're now on hepatic hydrothorax. So usually the hydrothorax or hepatic hydrothorax develops when the ascites accumulates, raising the interperitoneal pressure that herniates blood into the peritoneum, then into the pleural cavity. Okay, so there is accumulation of your ascites, increasing the intraperitoneal pressure. And what happens is it would herniates the blebs of peritoneum into the chest or the diaphragm that it bursts, causing gaining access to your pleural space, causing your pleural effusion. Okay. So in 80% of hydrothorax are usually right-sided. Again, 18% left-sided, and 2% could be bilateral. So diagnosis here can be one, if you do analysis in the that means that your pleural fluid protein is higher than in that of your acidic fluid. Oh my goodness. Am I still with you?
Yes po, Doc.
Okay. Please tell me kung nawawala ko kasi parang unstable ang internet ko ngayon. So your pleural fluid LDH is low, then your pleural fluid is oftentimes bloody. Predominantly, it contains polymorphonuclear leukocytes, and the amylase level is elevated, especially if it is coupled with pancreatitis or some form of malignancy. Treatment here would be limiting sodium retention and then lowering the portal vein pressure, therapeutic thoracentesis, will have lesser value, but the CTT should be avoided because the primary, although no, you can do your CTT, especially if it impedes already or it impairs already the respiratory function of your patient, but oftentimes a paracentesis can be of help here. Okay, your parapneumonic effusion in about 20 to 57% of patients hospitalized for CAP. Oftentimes in mga complicated pneumonia, you can have parapneumonic effusion. So oftentimes it is secondary to the lung infection, and then it followed by the migration of your inflammatory cells into the pleural space. And these inflammatory cells would release your pro-inflammatory mediator and then causing your effusion. So again, it is associated with bacterial pneumonia, lung abscess, or bronchiectasis disease. So most common cause of exudative pleural effusion is your parapneumonic effusion. And then about 10% would require an operative intervention, especially if the fluid is that of an empyema. So you can have a grossly purulent effusion, empyema, with a specific gravity of high of 1018. So that's a high specific gravity with a large WBC count of more than 500 cells per millimeter squared, and it has a greater 2.5 grams of protein. And what is required for you to be able to give out a diagnosis of parapneumonic effusion is it has to be with a culture for bacteria, positive culture for bacteria. So again, complicated parapneumonic effusion, it does not resolve without tube thoracotomy. So that means nga, the ultimate treatment here would be your CTT. So they have been classified into uncomplicated and decomplicated. So uncomplicated is treatable by antibiotics alone. Complicated if pleural space drainage is required. So that means a CTT is required. No? So this is your parapneumonic, complicated parapneumonic effusion. Now, there are stages in the development of your parapneumonic effusion. The first stage is that of the exudative stage, where there's a rapid outpouring of sterile pleural fluid into the pleural space. Now, pneumonia is oftentimes contiguous to the visceral pleura. Actually, again, no? So, pag nagno-pneumonia, again, effusion will occur if it is near or involves the visceral pleura. So when you examine the fluid, it contains low WBC count during this stage of exudative stage. It has a low LDH, the glucose still normal, and together with that of your pH. Now, insertion of CTT may not be necessary at this point. What you can probably give is your antibiotic to treat the infection. So the second stage is that your fibropurulent stage. Dito, there's already been a large amount of fluid. Mostly, again, your PMNs, bacteria, and some of your cellular debris. So it is in this stage where inoculation or formation of limiting membrane usually does occur. Okay? It contains a high LDH, glucose, and a low of your pH. Okay? So there's already been the formation of fibrin causing the locutions. No? In mga pleural fluids like pleural effusions like paraneumonic effusion, we should prevent. Well, this patients should not go into the fibroproliferative stage para we can remove the fluid easily. Otherwise, once the liquidation would occur, then thoracic surgeon must be part of the team. The third is the organization stage wherein now it will now be having a lot of fibroblast that grows in the visceral and your parietal pleura, causing your pleural peel. So pag ano na nga stage itong pasyente, then sometimes we submit this patient to surgery for decortication. So what happens here, there will be restriction to the expansion of the lungs. And one complication that may occur during this stage that empyema necessitatis and your aperture bronchopleural fistula. So how will you give a diagnosis of bronchopleural fistula? If there is failure of the expansion of your lungs even after the insertion of your tube, and then what you can see in the bottle, no, is there is actually bubbling, no, of the uh, fluid uh, in the drainage bottle. Okay, so the 30-day mortality is about 5 to 27%. And this is dependent on the extent of the mortality and of course the presence of comorbid condition. So understandably, in elderly patients, there already been a lot of comorbid conditions. So what are the risk factors for development of pulmonary effusion? Number one will be diabetes. Or in a patient who is immune compromised, in alcoholism, cancer, poor dental hygiene, an increased severity index of the pneumonia. So etiology-wise, we have both aerobic and anaerobic organisms that may cause your pulmonary effusion. In 35% of cases, it is caused by your aerobic organism. You have your gram-positive and gram-negative organism. Gram-positive organism is simplified by your strep pneumonia, your staph aureus. For gram-negative organisms, you can have your Pseudomonas, E. coli, Klebsiella, and H. influenza. Whereas that of your anaerobic organism, in 24% of cases, you can have Bacteroides. You can also have Fusobacterium species, and that affect the Streptococcus species. Or a combination of your aerobic and anaerobic, which is more common in 41% of cases. So what will be the clinical manifestations of your parapneumotic effusion? Definitely, you could have fever, you will have cough, and of course, difficulty breathing. Now, most patients really will manifest pleural chest pain because, as what we have said, that there's already affection of the pleura, and once your patient would inhale, especially deeply, then it will stretch the pleura, causing it to be painful. So you can have tachycardia and leukocytosis above 15,000, especially in complicated pulmonary effusion. So how about if you have an aerobic bacterial pneumonia with effusion? Oftentimes the febrile illness is acute, unlike an anaerobic wherein it is of subacute. You can have chest pains here, you can have sputum production, and when you do your CBC, it will show leukocytosis. But if you have an anaerobic bacterial pneumonia with effusion, it is subacute type. The median duration is usually of 10 days. Oftentimes, there is systole of alcoholism with episodes of unconsciousness or episodes of vomiting every after ingestion of alcohol. Then you can have weight loss with poor oral hygiene. Again, you can have leukocytosis and mild anemia in cases where you have anaerobic bacterial. So here, TB fusion. Again, when mechanism for the production of effusion into tuberculosis is that there is rupture of the subpleural caseous mucus in the lungs into the pleural space, or if there might be some hypersensitive reaction to the TB protein in the pleural space causing your diffusion. So manifestation and diagnosis, the classic manifestations of patients with TB, fever, weight loss, dyspnea. You can have also pleuritic chest pain. Then if you do some TB markers, it is positive in the pleural fluid. So what TB markers can be seen? You can have adenosine deaminase, interferon gamma, and it has positive also for polymerase chain reaction for TB. You can do some culture. I'm sorry. You can do culture and sensitivity of the pleural fluid just so that you'll be able to. This is culture and sensitive for TB bacteria. The needle biopsy of the pleura and the thoracoscopy. Now, I always see mga other physicians who ordered for EFP in pleural fluid. There is actually a very low yield of the EFP and the pleural fluid, so sometimes I don't request for that anymore. What is of important here is that to do your biopsy of the pleura and request for culture and sensitivity for your TB bacilli. So your effusion secondary to malignancy. Okay, this is secondary in cause of effusion, and oftentimes this is metastatic. So maybe from the breast, the lungs, and or from the lymphoma. So more frequent type of C of the lungs that causes malignant effusion is that from your adenocarcinoma. I think you know that adenocarcinoma is what? It is peripherally located, so papillary squamous will be located. That's why malignant effusion in patients with lung cancer is very common. So other sides of malignancy, you have ovarian, sarcoma, colon, uterine, stomach, and pancreatic. Actually, any other sites of malignancy can cause effusion if it spreads into the pleura, causing the effusion. Again, the mechanism here is number one, it could be a direct result, no? It could be a pleural metastasis with increased permeability of fluid going into the space, or there is pleural metastasis with obstruction of the pleural lymphatic vessels. Again, di ba, sabi natin kanina that absorption of the fluid is through the lymphatic vessels. So if there's some obstruction from the metastatic cells, then there will be accumulation of fluid in the pleura causing pleural effusion. You can have a mediastinal lymph node involvement with a decreased pleural lymphatic drain. Then thoracic duct interruption could be also secondary to the bronchial obstruction and a pericardial involvement. Second is it might be an indirect result such as hypoproteinemia, post-obstructive pneumonitis, pulmonary embolism, or post-radiation therapy. So manifestation is against the same, basically, no, dyspnea, which is out of proportion with disinfusion. This is what I was referring to kanina. There's weight loss, there's malaise, and there's also anorexia. So diagnosis here will depend, no, on how well you were able to extract from the history, and then signs and symptoms which are related to the primary site. There might be some lymph node enlargement, radiographic, pleural fluid analysis, biopsy of the pleura, and you can do your open thoracotomy. Again, just what I have been emphasizing to you, that you really have to palpate lymph nodes, no? Specifically that in the post-auricular area, post-clavicular area, no? Because oftentimes you can feel lymph node enlargement there, and you can do your biopsy from that side. So treatment here would be your CTT. Why CTT, not thoracentesis? Okay. Oftentimes, malignant effusion is recurrent. So therefore, what they call this drainage of fluid through CTT, so that after that you can you can introduce an disclosing agent for the pleura to adhere to each other. So that means that you will be eliminating the space or the pleural space so that there will be no recurrence of your pleural effusion. So that's why the treatment of choice here for the evacuation of fluid is your CTT. But of course, we have to submit your patient to an oncologist so that patient can be given the appropriate chemotherapeutic agents so that the effusion will not also be recurrent. Now, other types of cancers of the causes rather of effusion is come from mesotheliomas. So this arises from the mesothelial cells that line the pleural cavities and is oftentimes associated with exposure to asbestos. This might be benign, but this could also be a malignant. You have to remember that mesotheliomas is a precancerous lesion. That's why it can be also be malignant. The diagnosis here would depend, no, on the history. Usually patients is from 40 to 70 years of age with 20 or more years of exposure to asbestos. And the onset of chest pains here is usually insidious, and patient may manifest with shortness of breath, weight loss, dry hacking cough, and progressive fatigue. And this can range from very minimal effusion, especially if you catch it early in that condition, to a large effusion. Again, diagnosis. How would you diagnose effusion? First, of course, is your radiology. So what can you see is the blunting, no, of the claustrophrenic angle. So this is just the earliest, no, sign of of effusion. So what I can do here is to ask for a lateral decubitus, and you can see the layering of your fluid. Now here, as you can see, there are multiple layers of fluid. So that means that this patient is already having some form of a loculated type of pleural effusion, because oftentimes if it is not loculated, you can only have one line here, this area. So this one here, you look, oh, medullary, this one here, another one here. So this is one form of a loculated type of pleural effusion, and this cannot be managed anymore by thoracentesis alone. You have to insert CTT or chest tube so that there will be the loculation can be lysed. Okay, so okay, so here, no, you can see that there is, okay, there's a blunting of the here to the effusion. Then here you can see that there is already thickening of the pleura. This one is a mild effusion over the left side that caused the mediastinal structure to be close to the contralateral area. So again, sometimes kasi it presents only like this, no? Baka there's a complete opacification of the side of the chest. You can see that this is effusion if there is what do you call this? There's displacement of the medial sinus structure to the contralateral side. Because if this is kuan mga atelectasis, then the medial sinus structure should be pulled towards the same side. So ito kasi contralateral, so that means that there is effusion. So again, here this is just some of the radiographic presentations of patient with pleural effusion. As you can see here, this is a liquidated effusion. Okay. Now this one here will show to you that there is some form of an obstructive type of pneumonia. No? This is an obstructive pneumonia, and this is the lateral, no, view of these patients. Okay. So ito naman, once you see this one, this means that there is pneumohydrothorax. Okay. Now, how can you differentiate this one from a very large bullae? Is you have to ask for a lateral chest lateral X-ray, and if the layering would be from the back going into the front, then you're sure that this is pneumohydrothorax. And here, as you can see, no, this is your pleural line that signifies that this there is really pneumothorax. So when you see an X-ray, take a look at the presence of pleural line for you to say that there is really pneumothorax. So again, this is multiple layering of the pneumohydrothorax, so that means that there is circulation. Again, then you have to can ask also for chest CT scan. So here is the effusion. Now this is what is ano this is the itsura of the labs lang. This one is the effusion here. No, this is the example of your CT scan. So again, you do your thoracentesis to be able for you uh, to get a sample of the fluid and then submit it to the laboratory for examination. You can ask your patient actually, pwede nakalingkod siya. Oftentimes, I do it like this, no, where the patient is sitting down. And then I get the, ideally, the patient should be in the posterior axillary line, or it could the patient is not that okay. Then ultrasound guided tora, pwede siya ultrasound, no? Especially if there's multiple loculation. But again, as what I had said, if there's loculation, then what you can do is to request the surgeon to insert a chest tube. So again, you have to compare, no, before and after you do the procedure. Why are you going to compare before and after? Because you would want to see if there's some complication that happens, iatrogenic or what, after the procedure. So just to make sure na walang iatrogenic and pneumothorax that happens to our patient, then you have to request for a repeat chest X-ray after the procedure. Again, you can see also mga BAS or pneumonia after the evacuation of your fluid. So here you can examine your fluid crossly. So as you can see here, this is a bit turbid na pleural fluid, straw colored. And then have your pleural fluid examined for pH, uh, uh, LDH, glucose, protein. You can also request for serum amylase, total WBC count, the differential count. And then if you suspect that this is probably a pneumonic effusion, then you do your gram stain and culture and sensing. So ideally, if you're going to use the LICE criteria, then you have to extract also the serum LDH of your patient, serum protein of your patient, so that you'll be able to get the ratio. And then from there, you'll be able to uh, differentiate whether or not your patient's having some effusion from either exudative or supportive type of effusion. Okay, then you have can do your ultrasound of the chest. You can also do some chest CT scan. Then of course your MRI. Ultrasound of the chest. You can request this. No, number one is to be able to get the volume of fluid that you would want to aspirate, or if not, to determine whether or not you are dealing talaga with real effusion. Sometimes kasi a pleural plaque, no, or a pleural thickening can present as opacification of the chest, and uh, they won't warrant mga thoracentesis or CTT insertion. Also, I will be able also to identify other abnormalities in the chest with your CT scan and your MRI. So this algorithm of our management of patient with dual effusion. So if you have a massive, then you can do your CT insertion. Why CTT insertion? Because of the complication if you do it first with your thoracentesis. You cannot aspirate just plenty of fluid with one aspiration. So it has to be CTT insertion and controlled drainage no, after the insertion. It's only minimal with a significant layering on the cubitus that's more than 10 millimeters. Then you can do your diagnostic tora. Pero kung less than 10 mm yan, then think of a possible organization or consolidation. Okay. So if you have a unilateral effusion, then do the diagnostic thoracentesis, or you can do your pleural biopsy. So if it's bilateral, thoracentesis or thoracoscopy, if fluid is significant, then you have to consider the following conditions: congestion, cirrhosis, or it could be secondary necrosis. So after you have examined the pleural fluid, check whether these values are present. So if it is, then think of possible this is an exudative type of infusion. And this one, if it is not, then a transudative type. And then think of the different differential diagnosis for a transudative type of infusion. Okay, this is just to show to you how thoracosynthesis is done. Okay, so after doing your thoracosynthesis, but there is a recurrence of your effusion, you can do your repeat thora. Again, if there's recurrence, then you can do now your tube thoracotomy with or without thrombolytic or streptokinase injection. Or if not, then you can do your decortication. That means that you really have to open up the patient. You really have to decorticate for the thickened peel, no, the to remove the thick uh, pleura in the labs. Okay, so this is just to show to you the CTT. Okay, so what are the indications for tube thoracotomy? Cases you have a massive effusion, positive grand stain or culture, pH of less than 7, glucose of less than 60, and there's a loculated pleural fluid. So these are the indications for thoracotomy. And then your pleurodesis can only be done in the patients whom the effusion is recurrent. Okay, so one condition where this recurrent effusion is a malignant type of effusion, and if there is no response to your tube thoracotomy. As there are times kasi na if a malignant effusion, you did a CTT, then after it's drained, chemotherapeutic agent is given, so na-resolve and recurrence or there is no more recurrence of the effusion. But if there's a recurrence of the effusion, then sometimes we do your tube thoracotomy and then do your pleurodesis, so injection of your uh, medicines, no, to adhere the pleura. So there will be obliteration of the space actually. So what are the causes of effusion? Could be secondary to pulmonary embolization. So again, this is the most common symptom. Then you can do your spiral CT or pulmonary angiography. So we have discussed with PE, It could be viral. It could be secondary to the AIDS. It could be a hemothorax, especially if there is some trauma to the chest, a chylothorax. Okay, so pneumothorax. So after the effusion, we now have pneumothorax. So again, this is the accumulation of air in the pleural space. Now, when you take a look at the X-ray and you are suspecting a pneumothorax, then what you will look for is the pleural line. And this is the pleural line. Okay. Without the pleural line, then you might not be dealing with pneumothorax. Okay. So again, this is the presence of gas in the pleural space. You can have spontaneous pneumothorax wherein there's no history of trauma to the thorax, and it could be a primary spontaneous, it could be the secondary spontaneous pneumothorax, or it could be traumatic pneumothorax or tension pneumothorax. When you take a look at the X-ray, When you talk of primary spontaneous pneumothorax, there's an absence of underlying lung disease and there's rupture of the apical obliques. No? Of course, almost exclusively in smokers. 50% will have recurrence. Treatment here will be you can do your aspiration, but oftentimes we do CTT. Now, thoracotomy with stapling of blebs actually is done, but again, this is now an invasive procedure. Sometimes we just give an oxygen, especially if the pneumothorax is very small, less than 20%. A high oxygen therapy can help the patient without aspiration or without CT, insertion of chest tube. Your secondary spontaneous pneumothorax oftentimes is secondary to mga COPD. And it could be a life-threatening pneumothorax. Why? Because again, it is secondary. So in a patient who is compromised already with respiration because of the COPD, and then there's occurrence of the pneumothorax, then it can be a life-threatening. So maski laguti ay nga pneumothorax, that of course in the patients who are already respiratory compromised would be significant. So again, treatment here is to insert your CTP and then do your pleurodesis. Your traumatic pneumothorax again could be penetrating or non-penetrating. Penetrating again, oftentimes it is trauma kasi secondary to trauma. So you can do your chest tube insertion. Then your tension pneumothorax. This is of course during resuscitation or initiation of mechanical ventilation, and this is really a life-threatening. No, there are a lot of patients who really die from tension pneumothorax. These are actually large pneumothorax with shifting of the ventricular structure to the contralateral side. So this is really an emergency that really needs immediate attention by inserting your chest tube. Okay? Or sometimes kung wala pa test tube, wala pa surgery, then you can insert only, maski a needle lang, no? A large ball needle, but then have it, you release it into the air so that the air can be evacuated. So that could be a very good emergency procedure to do, especially if you cannot do your CPT yet or surgeons that day. So we now go to the, how many minutes do I have? Disorders of the mediastinum.
8 pa po, Dok.
Okay. Okay. Okay, so as we all know that the mediastinum is divided into the superior, the anterior, and the posterior middle mediastinum. So there are structures that are located over these areas, and then if you just know the structures there, you will know the differential diagnosis or what organ system to consider. Okay, so we have the middle mediastinum. We have here the heart, extending and transverse portion of the aorta. You have vena cava. You have the bronchocephalic artery in the veins, phrenic, trachea, main bronchi, and of course the pulmonary arteries and veins. So those are the structures in the middle mediastinum. Whereas in the anterior mediastinum, you have thymus, you have anterior mediastinal lymph node, internal mammary arteries, and the veins. So any abnormalities that you see on your chest X-ray involving the anterior mediastinum, take a look at these different organs. So in the posterior mediastinum, you have your descending thoracic aorta, you have your esophagus, thoracic duct, esophagus, and posterior group of your mediastinal lymph nodes. So knowing all this will give you the differential diagnosis, especially if you see some abnormalities within this middle, anterior, or posterior mediastinum. So yun lang po. You can further on your differential diagnosis. So these are the common mediastinal masses. In the middle, it could be a vascular, again, lymph node. It could be pleuropericardial or bronchogenesis. Again, anterior, because you have vascular masses. Well, sa posterior naman, you can have your tumors, you have your gangliosials, gastroenteric cyst, or it could be an esophageal diverticulum, especially if the what do you call this? The differential diagnosis is could be your acute mediastinitis. Oftentimes, this is secondary to rupture of your spleen. So, post-median sternotomy for cardiac surgery is one of the condition. that may predispose one to acute mediastinitis. Manifestation here would be an mediastinal infection, which is oftentimes uh, manifested as chest pain or dyspnea, and patients usually appear acutely ill. Now, treatment, of course, because this is perforation, then you have to do your repair of the esophagus and the drainage of the pleural space and the mediastinum from the, if there is presence of muscle. You can have also chronic mediastinitis, could be from granulomatous inflammation, or it could be from fibrosing mediastinitis, or you can have your pneumomediastinum. So this one is more common, especially in a patient who is intubated and is in the ICU. No, oftentimes it's secondary to alveolar rupture, or this could be perforation, rupture with esophagus, trachea, or main bronchus. Perforation of the trachea, especially during the intubation. No, you can have pneumomediastinum. So there is oftentimes dissection of air from the neck into the abdomen into the mediastinum. So there is actually the seepage of air, no? Could be from the neck or the abdomen into the mediastinum. Pero again, kaurugan din is because of the perforation of the trachea, especially during the intubation process. So disorders of the diaphragm. Okay, so you know that the diaphragm is the one that divides the abdomen and the what do you call this? The thoracic cavity. Okay. So you can have paralysis of the diaphragm. It could be bilateral, which is oftentimes severe, and then causes by your bilateral paralysis. Could be high spinal cord injury. Could be a traumatic, a thoracic trauma, multiple sclerosis. It could be also a muscular dystrophy. And the trick lagi kay bilateral niya, then you really have to put your patient into mechanical ventilation. It could be either nasal or it could be oral or oral naman by your mechanical ventilation using the machine. You can have diaphragmatic paralysis, could be unilateral, which is more common than bilateral. You can have nerve invasion, either from malignancy. What you can do here, the test that you should do in patient whom you're suspecting about diaphragmatic paralysis, the sleep test. So oftentimes patient is asymptomatic, no? You can only see this when you do a routine chest X-ray, seeing that the one diaphragm is higher than the other, no? Then 25%, there is reduction in your vital capacity. Okay, and kyphoscoliosis is one disorder of the chest wall that is very common. No, I can oftentimes say this one. Sometimes it's kyphoscoliosis or this is actually sandali. Kypho is anterior and lateral curvature of the thoracic spine. Of course, in 3% of the population, 3% are symptomatic. The severity of cardiopulmonary abnormality correlates roughly to the degree of the scoliosis. So the more severe the scoliosis, the more severe would the cardiopulmonary abnormality. Treatment here is, of course, to restore the normal curvature of the spine. You can actually ask the patient to, or refer the patient to orthopedic surgeon for alignment of the spine or maski lang ko ano, in uneven lines. Then disorders of the chest wall, you can have pictus excavatus or euphalo chest or pictus carinatum or pituitary. So when you talk about pictus carinatum, parang fano talaga siya. The lower portion of the sternum is displaced posteriorly, and the anterior ribs are markedly bumped. So pictus carinatum is the reverse of the above, and there's the picture here. Okay, this excavatum, there's a sort of excavation. There's pictus carinatum. No? There's an anterior uh, bulging of the chest. Okay, so uh, the topic is I'm done already actually with my lecture. So thank you very much for your attention. Would you want me to give you the copy of the slides?
Yes po, Doc.
Oh, see. So I'll just Just give me your email address so I can mail it to you, okay?
Okay po, Doc. Thank you po.
Oh, thank you so much.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Thank you, Doc.
Bye-bye. So don't forget to give me the email address.
Thank you,
Okay
Doc.
po, Doc.
Bye-bye.
Thank you, Doc. Bye, Doc.